You're listening to the RN Mentor, a podcast designed to document and bring you the work and experience of some of the most influential nurses in our profession. We will be sitting down and having a discussion with the leaders of today's nursing world as they share their work, how they navigate their nursing path, and their views on the future of the profession. My name is Ali Tayeb. I am a registered nurse, United States Navy veteran, a Jonas Veterans Healthcare Scholar, and your host for the RN Mentor. Hello, welcome to another episode of the RN Mentor podcast. I am very excited to be joined today by Dr. Summer Thompson. She is a mental health clinician, scholar, writer, and fierce advocate for mental health in underserved and marginalized populations with a particular passion for veterans, monolingual Spanish-speaking clients, the LGBTQ community, and transgender and gender diverse youth. She currently works as an adolescent and adult psychiatric nurse practitioner for community psychiatry, an expert nurse witness for California Board of Registered Nursing, private legal consultant, and an assistant health sciences clinical professor at University of California, San Francisco. Dr. Thompson's journey to nursing began with her service as a Peace Corps agriculture extension volunteer in Nicaragua, which led to her to attend Johns Hopkins School of Nursing as a Coverdell Peace Corps Fellow. She later commissioned as an officer in the United States Air Force and served for 4 years at Traverse Air Force Base. Dr. Thompson completed her Master's of Science in Nursing and Doctor of Nursing Practice at University of California, San Francisco. Dr. Thompson is currently a member of the World Professional Association of Transgender Health, has published scholarly articles on a variety of mental health topics, including trauma, emotional support animals, and treatment of antidepressant side effects. Welcome to the show, Dr. Thompson.
Thank you. I really appreciate you having me here today.
We've been connected for a while. I'm so glad you said yes to being on the podcast. Lots of topics I want to talk to you about. But as I do with all my guests, we'll start with, how did you get started in the world of nursing?
Like you said in the introduction, I did the Peace Corps after having gone to Gonzaga University, and I got my first degree in philosophy. As you can imagine, the philosophy jobs are few and far between out there in corporate America. So when I was in the Peace Corps, they had they had a program available that if you applied to Johns Hopkins, you could get a fellowship, which provided a significant amount of funding. And I figured, honestly, I went into nursing because I figured I could work 3 days out of the week and I could serve for 4. And so that was my big plan. Is I went into it with the hope of having a job where I would earn a decent salary and have a good career, but also I could serve the majority of the days of the week. And it surprisingly, it became a passion of mine.
Oh, that's amazing. So no prior to this, was nursing, were you exposed to nursing at all prior to deciding you're going to use this fellowship or anything like that?
I was exposed, well, I come from a very long family history of nurses. My grandmother was a nurse during World War II in the Army Nurse Corps.
Oh, wow.
She's 100% service-connected veteran. My multiple aunts on that side, because my father's side of the family were also nurses. My sister is also a nurse. So many nurses within my life.
So there's some influence on that end of the world.
Definitely.
That's awesome. So you became a nurse, and what was your first job coming out of nursing school?
Initially, out of nursing school, I went to UCLA. They recruited very heavily from Johns Hopkins. And so it was a big move for me to go from Baltimore over to Los Angeles. As you can imagine, a huge culture change, weather difference. I worked on the acute inpatient adult unit, essentially where adults go if they're having a psychiatric crisis. It was eye-opening and a heck of a place to cut your teeth as a new graduate nurse.
That's great. Now, did you know if you were going to, were you already interested in mental health prior to taking that role, or?
During nursing school, because you do get exposed to so many different specialties, I really enjoyed psychiatry for the fact of being able to connect with people. I love hearing people's stories. I think that's the the biggest part that I still enjoy about psychiatry today is just hearing about people and really being able to, walk in their shoes maybe for a second and hear their stories. That's what I really enjoyed about it in nursing school, and kind of led me down that path of working in mental health.
Oh, that's great. Now, did you, as you were looking at, as you were working in that role, at what point did you decide you were going to go into the Air Force, or change of scenery from that perspective?
It was a very strange path. I was able to get a job as a contractor at Landstuhl, Germany. And when I was there working as a contractor, I worked on the triage service for service members who were being air evacuated out of Iraq and Afghanistan, contractors and whatnot, for psychiatric issues. The big issue that they had there was people were getting sent to the inpatient psychiatric unit on base, which was pushing out the local population. After being exposed to doing that for approximately 2 years, like, I just had this fire in my belly, and I was like, you know what, I'm going to join the service. I feel like I could do this and help people out. And so I commissioned in Germany, which is a strange place to commission outside of the United States. And then I was stationed at Travis Air Force Base, so they shipped me from Germany over to Travis Air Force Base in Northern California.
So how was that transition going from having worked in the civilian community, going into like the military community? How was that for you?
It was strange. I will fully admit that, because I didn't go into the military as some 18-year-old, fresh out of high school, or someone right out of, college. I was a 32-year-old adult who had a career. It was a little bit difficult for me. I will be fully honest, just because there is so much more oversight that you experience within the military. It was annoying in that sense. I was like, I don't understand why you guys want me to do all these things. Like, I'm a competent adult. Please just leave me alone. But it was also wonderful for the camaraderie. I still am extremely close to so many nurses that I served with. We get together regularly and have bonfires, even now.
That's great. Yeah, that's one of the things I hear a lot about with people who served, didn't go directly into the service, but they initially find it very difficult. It seems like it's easy. The younger you are, the easier it is to transition into the military.
Mm-hmm.
And at the same time, I want to say, if you've already had sort of a life prior to the military, the transition out might be a little bit easier as well, because you haven't been so, like, the impression I think of joining the military is a lot stronger when you're younger, because you're still building an identity, versus
Mm-hmm.
a little bit later where you already have an established identity, where it does sometimes, I've heard it does sometimes conflict with military life, just because you already have that identity, and you're not indoctrinated. It doesn't feel as you're as, I don't say indoctrinated.
I think that's actually
brainwashed.
That's an appropriate
Maybe brainwashed. You're not as brainwashed as you are as an 18-year-old going in. So
I love it.
So yeah, I definitely drank the Kool-Aid when I joined. I went right after high school. So
goodness.
Yeah, to transition out. I always tell people I'm still transitioning out. I've been out 20 years, and I still say I'm still transitioning out of the military. So yeah, it's a long process.
Undeniably.
Yes. So you served at Traverse Air Force Base, and what made you decide you were going to leave the military and go back to the civilian world, other than perhaps some military lifestyle wasn't maybe suited or didn't?
My goal with going into the military was that I wanted to become a nurse practitioner. And so it was, you look at the exponential cost of getting a graduate education nowadays, and you can,
it
could be $100,000. So I was like, well, I have a couple of options. I could go to USHS over in, the DC area and have that be an option, or I can use my GI Bill. You serve 36 months, you have that lovely, lovely GI Bill as an option. So when I was looking at those options, if you do go into USHS, you owe, time plus the time you spent in. And so that would be at least another, plus a PCS, that's another 8 years in the military.
Yeah.
I was like, oh, but there's that aspect of it. Also, psychiatric nurse practitioners had an extremely high deployment rate during that time period when I was in, which was a factor as a mom with 2 little kids. I'm like, I don't want to end up making rotations to Iraq and Afghanistan. So I decided to get out, and being that I was in the Bay Area, UCSF was like the obvious choice as far as psych NP programs.
Now, I know you've said you had that exposure going into psych NP. What made you decide that a psych NP career route was for you? Why not just stay bedside?
That's a good question. Part of bedside psychiatric mental health nursing is very physical. Like there is a certain aspect of it. Like there are, God bless the nurses that can stay and do it for 20 years. Because it can be very physical. You have patients who are not in a mentally well space, and the potential for injury and the long-term wear and tear of doing that kind of work definitely takes its toll on you. I always felt that I was not quite achieving my potential of like things that I could possibly do. And, as a bedside nurse, especially when I was in the Air Force, I was charge nurse, I was managing 25 people, kind of a situation on a psych unit. And I still felt like, I feel like I'm not quite living up to my potential of what I could be doing. And it seemed like that natural transition of really trying to challenge myself with like stretching that brain power and doing something completely different by going into the psych NP role.
It's always that next step that kind of seems to be the driver for a lot of people who go into their master's and doctoral programs. Now, you did eventually end up pursuing your doctoral degree.
I did.
And I want to get a little bit into this. So what made you decide to go into a doctoral program? And then after that, I want to talk about scope of practice with you since you are in California.
Okay. Honestly, I love learning. If I had the possibility of being in school again right now, I would definitely do it. One of the big aspects of it was I still had much time left on my GI Bill. So I was like, well, this is, previously you had to use up your GI Bill within a certain period of time. And I'm like, well, I don't want to be running against the clock and not being able to get like those months out of my GI Bill. So I was like, okay, well, I know that UCSF is covered 100%. I'd be able to get through the entirety of the DNP program without having to worry to pay for it. This love of education, again, with the expanding your brain power and being exposed to things, like within the course of my career, I've never had a situation in which like learning something new or getting a certification or, trying to, broaden just any type of knowledge you have has never not served me. So it seemed like the next, again, logical step for me as far as, my education.
That's fantastic. Now, you trying to get my thoughts together here. So you went into the DNP program, finished the DNP program. Were you still working? Were you working as an NP when you were going through your DNP program?
I was working at community psychiatry where I'm currently working now. It was a lot, when you're working full time and being a full-time mom, as well as going to school and a doctoral program it was a lot of juggling going on, but I was able to make it happen.
That's great. Now, I do want to talk to you about scope of practice from where we are versus states that have full scope of practice with nurse practitioners. How's the scope of practice in California for you? Like, how do you work with it? And where do you think your scope of practice should be in California, or when we talk about full scope, or being able to, not you have full scope, but being able to practice your full scope? What's your thoughts on that?
Oh, you're asking the controversial questions now. I see.
It's not, I don't think there's a controversy about it. I just, there's just different points of views.
Okay, fair enough. That works. Within the state of California, they do require that you have a supervisor. In all honesty, it just depends on where you practice and what that actually looks like. I mean, some individuals pay a physician $5,000 and they put their name down and they never talk to them once over the course of like their practice. And like technically, like that fulfills the legal definition of like having a supervisor. And so, I mean, in the context of like, there's the letter of the law, and then there's the, the spirit or the intended like thought of the law. And so, many people follow the letter of the law, and in reality, all it is nurse practitioners paying somebody to put their name on a piece of paper, which is a joke, really. That's not how it was really intended to be written. They did recently pass that legislation that they are going to allow nurses to be able to attain full scope of practice after, was it 2 or 3 years of practice after getting signed off by a physician?
I think it's like 3 years.
Yeah, I am excited for that actually. Like that's going to be very exciting to be able to practice to the full extent of my scope. I have mixed feelings about the whole process. There, advanced practice nursing has an issue right now with the quality of education that's being put out. I know this is a topic that's discussed quite often amongst nursing circles and also amongst physician circles.
Yeah.
There is concern that we are not creating quality clinicians that are going to be able to, provide adequate care to patients. It's a valid concern, no doubt. I think it's just a matter of coming to a consensus within the nursing world regarding like how we are going to regulate ourselves and create a standard of care that actually addresses that issue and allows us to be able to provide quality, competent care to our patients.
Right.
I think that nurse practitioners are completely capable of providing care to patients without having a supervising physician. But how do we make sure that clinicians are competent? Like, I think that is the issue that we're really facing right now. And it's not really being addressed by the higher organizations within like advanced nursing practice, truthfully.
So you think there's I mean, each state, that is the problem, that each state kind of does their own thing and there's no national standard of where competencies should be, or because if you look at the schools that are out there, there's just so much variation.
Yeah.
I mean, there's some standard number of hours that need to be met. But then there's like nurses like yourself that have had significant experience prior to going in psych nursing, prior to going into psych mental health. So you can always make the argument that you've had years of experience in the field prior to going into that. But then at the same time, we have new grads going straight into NP programs, which has its own pluses and minuses in my brain. I used to be of the mindset that you have to do so many years before you go into. I think it would make you a better NP. But I've seen some incredible NPs that have gone straight into an NP program, and they've come out incredible NPs, right? So yeah, I agree. There's a lot to be worked out, and I think we do ourselves a disservice by not having some kind of a baseline core competencies that we look at. So there's a national standard where we can say this is our standard, and isn't, oh, this state does this, oh, by the way, this other state does this. And there's so much differences in scope and what they allow and what they don't allow. But research does support the fact that there should be full scope of practice capabilities. I mean, that's a given, but it's just a matter of I think part of the problem is we have difficulty as a profession talking to the specifics as to why we should have. I'm not a nurse practitioner. I don't know why I'm saying we as a profession, I should say.
There you go. That works.
So very cool. Now you decided at some point that you were going to, I mean, you have selected some very specific populations that you are interested in serving, and it's primarily very underserved populations. What got you interested in those populations? And can you tell us a little bit more about that?
Sure. The monolingual Spanish-speaking population in particular, especially living in California, like there's a huge Spanish-speaking population. A big reason, well, I learned Spanish when I lived in Nicaragua. I got C's in high school. And just like for those of you out there wanting to learn Spanish, it's possible even if you didn't do well in high school Spanish. But I became fluent in the language, and there is just a shortage of psychiatric or mental health providers who speak Spanish. And there are nuances that get lost through a translator if you're trying to stumble through a psychiatric assessment. And it's so nice to be able, I see patients' faces light up when they're like, oh my gosh, you speak Spanish. Thank goodness I can have a conversation with you. They just get left behind. I have had so many instances of patients just not being heard. And like, honestly, half of the time they come to me and it's not even a psychiatric issue, but because it's a medical issue and they only speak Spanish, it's never addressed. And so what I'm able to do, like I end up being more of a case manager in that way. I write a nice, like long letter to their regular clinician being like, hey, this is the problem. I think you should probably address it. And then the patient actually gets the care that they need. So it's just people not getting care. I mean, it happens to be that they speak Spanish, but like any person not getting the care that they need, that it's someone who really cares about people and want to see them like get their healthcare needs met. Like it's a thing that I try to focus on. With the LGBT community, I mean, I live in the Bay Area. If you want to talk about one of a very dense population of LGBT individuals, it's here. Again, they're very marginalized. So much and what it ends up doing is it creates barriers to care that don't need to necessarily exist. And my goal is to try to pull down those barriers as much as possible. I don't have it here because I'm not in my office. However, in the office where I work out of, over my right shoulder, I have a pride flag as well as a trans flag that's above me. They're small, but it's one of those situations where people see that, and especially if they're a member of the community, they're like, oh gosh, this person maybe might listen to me and hear my concerns. The interesting thing about working within that community is once word gets out, especially among the trans community, that you're a person that works with them and wants to hear them and help them, by word of mouth, people come to you. It's been fascinating, and that's why I joined WPATH, because I felt as though I was getting a number of patients that were within the trans community, and I didn't really have the scope of knowledge that I needed to provide competent care. And so, through that process, I am working on getting my certification within WPATH, which is you have to get 50 CEUs and have a mentorship. It's a very intensive certification process.
Yeah, that's fantastic, because two things you kind of touched on, and I think it's two topics we don't really talk about a lot in higher education. Is you will have patients with that speak different languages. I mean, even in my own family, where we have, like, when my grandmother was here, she only speaks Farsi, right? And she needed to make physician visits, and she always have to have somebody with her, or the translation services. It loses something something is lost in translation when you don't have somebody that speaks your language. Some of the nuances are missed. Some of the the feelings that go into and the emotions that go into the conversations get lost in the translation, and it becomes very mechanical. And so for something like psych and mental health, where it is a lot of emotion and opening up to someone, some of that information, it gets lost if somebody's translating for you, right? Exactly. So you tend not to open up as much. It's definitely being a Spanish speaking is a huge plus, but I think it's something that we need across the board from a recruiting perspective, of actively recruiting individuals that are and incentivizing them going into the field, because there's such need. I mean, especially like in California, where we have such a diverse population. You in the Bay Area, me in LA. I mean, there's so many people that are monolingual that don't necessarily speak English, or don't speak English well enough to communicate what they need to when it comes to healthcare and psych mental health. So that's great. That's great on that. Now, can you tell me a little bit more about this certification? Is it open to everybody? Do you need to be, for a mental health perspective or provider? What is the incentive for somebody other than wanting to? What like key areas do they kind of tap into, where you think would be beneficial? If somebody's mental health listening to this podcast don't know about this, what is the benefit for them?
The benefit, in all honesty, WPATH focuses on all healthcare providers. So they touch on all aspects of transgender care. And so, of course, everything is a small piece of this whole puzzle that goes into the care of any specific type of individual. As a mental health clinician, I feel that it's really important, because you do need to know all the various aspects that go into caring for a transgender individual, because there are different aspects of it. There are nuance, and we're talking about hormones. Like if we're making physical transitions, these are different parts of the care of a transgender individual that are going to need to be understood by the clinician. So I think a big motivating factor should be, for anyone who's wanting to go into this, is it's not the role of the transgender individual to teach them, or to teach the clinician about what is the standard of care and how they should be treated, and all the aspects that go into caring for a transgender person. And so I really feel like the onus is on the individual clinician to educate themselves. And that's what I appreciate about WPATH is they provide a very robust way in order to achieve that. And so I would say for any clinician, regardless of specialty out there who has an interest in serving and working with the transgender community, like this is a great way to like take hold of that responsibility as far as educating yourself about this population so that you can provide competent care, but also not put the burden upon the patient to educate you about them and their care.
Yeah. Now, this is a great topic because I don't think we talk about it enough. And I remember myself when I was bedside, I had a transgender patient, and I got to the point where I'm like, I don't know what to do. Because it was very foreign to me, right? I hadn't had that experience in nursing school. Nobody talked about it in nursing school. But here I was as a new grad, and I had to go ask. And luckily, my preceptor was informed enough to tell me, some of the things I had to do. Not that I had to do, but that would be, appropriate, right? Because we had to put in a Foley, and it was one of those things that I was like, how does this work type of a thing. And he came in with me, walked me through the process, and it wasn't, it went actually very smoothly, and everything was fine. But I found myself at a point where I'm like, nobody has talked to me about this, and here I am with a patient that needs care, and I don't have the skill set necessarily or the knowledge of how to approach this. So here's my question for you. Should this be something, and I know the answer for me, but should this be something that we spend more time in undergraduate programs?
100%. We talk about treating diverse patients from a variety of ethnic and backgrounds, and trying to be aware and I don't like to use the word competent, more humble to like the fact that these people have a different experience to our own. And I think that needs to be extended to like the gender minority population as well. They're out there, they exist, and they have a right to quality and competent care. I think that nursing programs are painfully slowly starting to come around to the knowledge that, they are also responsible for teaching young nurses how to provide competent care to these individuals, or at least to start that conversation so that, like you said with yourself, like you're not like stepping into a room with a transgender patient and then having your jaw drop on the ground because you don't know what to do or what to say or how to interact with them in a way that is going to at least not shut down the communication process when caring for those patients.
Yeah. I mean, it wasn't, for me, it was, I definitely became uncomfortable, not because I was in the room with a patient that was transgender, but I became very uncomfortable because I had to take care of them, and I didn't have you can say competency. I didn't have the competency to do it because, again, something I've never learned about. We had male, we had female, and that's kind of what we did. But like the conversation, I hadn't even been in that conversation. When growing up in LA, I knew transgender people. I had worked with transgender people, but now I had to take care of a transgender patient, and that's where the uncomfortable. And I'm sure that translated, across the room as soon as I walked in. And it wasn't. I think it's because I was uncomfortable because I didn't have the knowledge that I thought I should have in order to take care of this patient. And I kind of feel, and I felt bad more for the patient than, even myself, because because I knew that was translating when I was in that room. But luckily everything worked out fine, and we took care of the patient at the end of the day, but I had to borrow somebody else's skill set to do it. So that's great. That's great information. So now you're still practicing. What does your practice look like now? What is a daily role of you, especially we're still in the middle of a pandemic, unfortunately. Every time I do one of these, I'm like, we're still in the middle of a pandemic.
The majority of my role is medication management. So I have patients come to me. We see how they're doing on their meds, treating them for whatever the issue is, talking about side effects, whether the medications are doing their jobs, and then kind of going from there. Then the other aspect of it is I see a lot of patients who I've been seeing for the past 5 years, and their medications are at a stable place. And a lot of it's me checking in with them and just making sure they're doing okay. The relationship with a mental health clinician is different than that, I would say with primary care. Like I get a 30-minute interview, I get 30 minutes to really sit with people, and you can have a decent conversation with someone in 30 minutes, ask about their kids, ask about their grandkids. How's work going for you? Do you feel like the meds are doing their job? Like, how can I help you to be able to function at your most optimal place? I appreciate that there is very much there's a relationship that gets established there where you can really, get to know one another and, make sure that they're doing well so that's with established patients. With new patients, a big portion of it is doing evaluation. You sit down and you try to figure out what's going on with people. So often I get patients who come in and, there is a lot of stigma associated with mental health. People are afraid to come and see people like me, which is crazy because I'm amazing and super fun. But, it's one of those things, it's like trying to not perpetuate that stigma associated with mental health and trying to help open that door, being like, hey, we can help you to feel better. Let's figure out what's going on with you. And sometimes that means medications. I try to be really open with people that I don't get paid by the pill. Sometimes people want to get an evaluation and have a conversation about meds and see what their options are as far as treatment are concerned. And at least start the conversation about that. And sometimes I feel like if you don't press and pressure people to do things that they feel uncomfortable with, they're more likely to swing back around and be like, hey, a lot of this stuff resonated with me. Maybe we can have this conversation further. I get other people. I had a situation today. I got a patient who came to me with on medications, but just not feeling like they were being heard by the person that they're working with. And I'm like, okay, well, let's have a conversation about that. Like, what's going on with you? What are they doing that I can try to avoid doing so that I can help you get the care that you need, that you don't feel like you're getting right now? Like a big part, it's listening. It's listening and also hearing people. Because you can listen and not hear what's being said. Like that happens all day long, all the time. But listen and really hearing what people are saying. Because a lot of times what comes out of people's mouths isn't what necessarily is the issue. Veterans. I'd like to use the example of veterans. I love working as a vet. I love working with veterans, but we are a very specific population. So whenever you work with a vet, vets always get tagged as being grumpy or being angry. Veterans, when they get like heated or they have conversations, they stand up, they start gesticulating. You see the knife hands getting thrown around. And it doesn't mean that they're aggressive or grumpy. That's how vets communicate. When you're in the military and you start getting like emphatic about something, you stand up. Like that's how you have a conversation. You don't do it sitting down. And so, people who have been told that they have like anger issues, and it's like, no, they're a veteran. They're just standing up. That's how you have a conversation. It's fine.
I needed you in one of my HR meetings about 6 or 7 years ago. Where I was counseled on how I was talking. I'm like, I'm not angry. When they're like, oh, you're angry. I'm like, no, I'm really not. This conversation is making me angry that you think I'm angry.
Right. But you're like, no. You're like, oh, man.
Yeah, I've had to do, and I want to talk about veterans a little bit more now. You brought it up, but it's so many organizations say we want to hire veterans, but don't know how veterans act, and they don't see it as a different culture. And when they don't understand it, I know so many veterans that have ended up in HR because, and even myself, I've gone there unfortunately more than once because of something that I've talked about or something that I've said that was perfectly normal when I was in the military, but now all of a sudden it's seen as aggressive or angry or so it's I've spent, I said, I'm still in transition after 20 years of being in the military, but transitioning into the civilian world, because up till today I still see myself modifying behavior so I can fit in, right? And I think that goes with, I think, every veteran, regardless of how long you're in. Some of those behaviors you pick up, it's lifelong, and you have to either unlearn them or modify the behavior, because most of the time we're going to be in environments that aren't filled with other veterans that are going to understand what we're talking about, right? But I don't want this to turn into a therapy session for me, but free therapy for the podcast. So yeah, but it's very true. It's very true. Now, with the veteran specific, I want to ask you, because I know with everything that's going on with Afghanistan right now, I just read that the number of calls into the VA for psychiatric mental health has increased.
Oh, I don't doubt it.
Over the past week, because I know a lot of people felt very vested in that. And not only the country, but the population and the relationships that they built over there. And it feels very, there's definitely a lot of emotions going on. And if anybody follows my Twitter, they would have seen I'm not happy about it. But I know there's a shortage overall for mental health providers across the country. Is there a place for nurse practitioners to fill that gap specifically? Yes, for the general population, but specifically for the veteran population, because most of our veterans are getting their care outside of the VA system. Is there a place where they can, the civilian nurse practitioners or mental health providers to get the proper, I hate using the word competency, to get the skill set they need to treat the veteran community or to help the veteran community?
To my knowledge, there are a number of residency programs that exist within the VA across the United States. And so that is something that the VA, I feel like, is doing very right in terms of psychiatric mental health nurse practitioners that a lot of other organizations just don't have the bandwidth for at the moment. I know the San Francisco VA over at Fort Miley, they have a residency program that they run a number of people through every single year. And they do a fantastic job of exposing new graduate psych NPs to veterans and veteran issues so that they can gain that competence. I would love to see an expanding of programs like that within the VA. I think that, I recently got called by a vet that I served with. She was actually in the VA, like she worked for the VA at Travis Air Force Base while I was active duty. And she called me and said, Summer, we have the VA at Martinez and we have like 3 open slots. One of our psychiatrists just left and we are really hurting for psych NPs. There is a huge need right now within the VA for clinicians, such as like psychiatrists or psych NPs to be able to provide care to veterans. But also, I don't know, like for civilian clinicians who are going to be working on the civilian side of things who also treat veterans, I don't know that there really is much in the way of resources in order to be able to help them with getting the competencies in order to be able to treat vets. I don't think that actually exists. If it does, I don't know about it.
Yeah. I haven't seen, there isn't a whole lot out there as far as helping the civilian community assist the veteran community, because the default answer it tends to be, go to the VA.
Yeah.
But again, we have, like I said, most of our veterans are not seeking care at the VA system. And I feel like I'm bringing my issue, my PTSD up a lot. But so I have, I'm not a former, I have PTSD from my service, and I went to a private, and I've never used the VA system. I've always had health insurance, so I've always just used the civilian. I've not, but I did actually seek a therapist at one point many years ago, where I had a difficult time, and like within 5 minutes in the conversation, his answer was like, "You should go to the VA," right? Where I was like, but I'm already in your office, right? So I think there's definitely a gap in the civilian community for treating veterans outside of the VA system, because the VA system, I mean, the backlog still continues. Getting care isn't as optimal as it could be. They are constantly, there's a lack in personnel, right? They have huge transitions between people coming and going, and not a very stable environment for a lot of veterans. Even though when they do provide care, they provide good care, it's just that it's not optimal as it be. So that's a lot of, and again, a lot of veterans don't even want to deal with the VA system and just want to use their private health insurance. And I think that's where there might be a gap. Maybe something we need to think about as a profession of how are we closing that gap for, because I don't think anybody else is.
Yeah, no, I completely agree. As it's interesting, I also have PTSD from my time in the service and service connected for that. I see a therapist on the civilian side just because getting in to see, I mean, it's kind of confounded for me because I did work in mental health, like in the local area. So I know a lot of clinicians. So it's an odd experience for me. Like, I don't necessarily there's too much intermixing of like water. I might end up with somebody I know. I'm like, no, I'm good. But I get the rest of my care through the VA. Like, I almost exclusively get all my care through the VA here in Northern California. And I'm there, sometimes you have to advocate for yourself. That is a part of it, but I feel like in civilian health, that's a reality as well. Like, if you're not getting the care that you need to step up and talk about that piece of it. But there is, the VA could be doing more, undeniably.
Yeah. I have my sister-in-law does. She's a lawyer, and she does work with the veteran community, and there's all the resources for her to learn about, whether it's learning about the military culture, learning about there's free programs for her to sit down, learn about, and be able to provide that. I wish something like that existed in the civilian version for healthcare.
That would be
amazing. I think that research just doesn't exist, unfortunately. All right. Thank you so much. Anything else that you want to share? I mean, you're doing amazing work, and I wish you the best of luck. Anything else that you want to share with our listeners?
I would just add to normalizing taking care of your mental health. If that means seeing a therapist, then see a therapist. If that means seeing somebody for medications, whether it's your primary care provider or a specialist, I say do it, especially right now in the middle of a pandemic. I mean, life is stressful in general, right? We don't even need to throw a pandemic on top of it. Just to say, is like, adulting is hard, like regardless of where you're at in the process, unless you are a multimillionaire and don't have to worry about that stuff, which most of us aren't. But the pandemic added quite a few extra layers to all that stress, and like, there's no shame in getting the mental health care and reaching out to people if you need it. I always tell people, it's easier to dig somebody out of a 3-foot deep hole than a 12-foot deep hole. I'd rather be pulling somebody out of a 3-foot deep hole. And so if you notice that you're in a 3-foot deep hole, stop digging and give somebody a call to help get you out of it. We're here for you, and we want to help people out.
Thank you. That's awesome advice. Thank you so much. We've been listening to Dr. Summer Thompson. I wish you the best. We're staying connected, and we shall see everybody soon with our next podcast. Thanks very much for joining us. Bye-bye. You've been listening to the RN Mentor with your host, Ali Tayeb. Please don't forget to visit www.alirtayeb.com. That's www.alirtayeb.com for podcast notes and resources. And don't forget to subscribe. Until next time, I wish you fair winds and following seas.